Thank you, Dr.
Thank you,
Prasad.
Dr. Prasad.
Yes, sir.
We'll move to the next presentation if the judges are happy about the question time.
I'm okay.
I'm okay.
Thank you, sir. Shall we move to the presentation number 4, presented by Dr. MMPT Jayasekar. Over to you, Dr. Jayasekar.
Then my topic is knowledge, attitude and practices on COVID-19 among healthcare workers in selected hospitals in Sri Lanka. Lack of knowledge, inadequate practices and negative attitudes among healthcare workers can subsequently lead to themselves falling ill and putting others' lives at risk. Our main objective was to assess the knowledge, attitude and practices related to coronavirus disease among healthcare workers in selected hospitals in Sri Lanka. This descriptive cross-sectional study was conducted in 12 hospitals. If you see this Sri Lankan map, you can see from Jaffna to Tangor, there are hospitals all over the country. So this was done between June to September 2020, before the invention of a vaccine. Data was collected using self-administered questionnaire. The knowledge had 10, attitude 15, practices 15 questions respectively. Cut-off level more than 75% for the good knowledge, more than 87% for good practices, and mean score more than 46 is considered a positive attitude. Software statistics and data sciences version 40 was used to data analysis. The comparison was done using multivariable analysis. If you look at the results of a study population, there were 67% females with the 33% of males, and 52% of nurses and 48% of doctors. 64.9% had good knowledge, 50% had positive attitude, and more than 95% practiced preventive measures. And 84% disagreed on giving minimal care to COVID-19 patients. And 51.5% not for it to treat COVID-19 patients. Good knowledge of COVID-19 was associated with being a doctor. Good practices were associated with adequate knowledge, being married, and being a doctor. So in conclusion, although overall knowledge, attitude and practices are satisfactory, it is important for healthcare workers to have excellent knowledge, 100% adherence to preventive measures, and maximum positive attitudes towards COVID-19 for the purpose of safeguarding themselves and mitigating the pandemic. Thank you.
Can I ask a question?
Yes, sir.
Yeah. So, what do you mean by practices? What were the practices that you tested?
So, hand washing, distance maintaining, and when they're looking after the patients, mainly the using masks and like mainly the hand washing, distance maintaining. Once they look after the patient or take care of a patient, using PPE, those are the things we use.
So basically infection control practices.
Yes, infection control practices.
Okay, right. And you said so many, a certain percentage disagreed on giving minimum care.
Yes.
What do you mean by that?
So there was the attitude questionnaire. So there are about 15 attitude questions. So there's a one question asking, it's a Likert scale one, whether you are you agree on giving lowest care to the COVID-19 patient. So some people agreed, some people not agreed, disagreed.
That must have been the Sinhala or Tamil, no?
So it is in English because this was done in the nurses and the doctors.
So
questionnaire was in English.
Okay. I couldn't understand the question. What exactly do you want to find out in that question?
So not only that particular. So I am agree to give minimum care to COVID-19 patient. That was the question. So the Likert scale, agree, disagree, partly agree, kind of. There were 5 things to answer.
So minimum care meaning I am agreeing to give minimum care, but I disagree to give more than minimum care or something like that.
That's that is one of the questions. The other questions like, I am happy to monitor blood pressure of a COVID-19 patient. Agreed, not like that. The other question. This is one of the questions. The overall care at the end of the question. This was the overall care given to a COVID-19 patient. So most of them disagreed to give minimum care.
Meaning, what do you mean by that statement that they disagree to give minimum care? What did you mean as the person asking the question?
That means they are happy to treat the patient. Vice versa.
Thank you.
Thank you, sir.
Any more questions from the panel?
I'm fine.
Thank you, sir.
I'm fine.
Then thank you, Dr. Jayasekara. Shall we
Thank
move
you.
to the
Thank
next
you, Dr.
presenter?
Thank you, sir.
Presentation number 5, presented by Dr. K.I.P. Prabhani.
Hello, I am K.I.P. Prabhani from Faculty of Allied Health Sciences, University of Peradeniya. I'm going to present a systematic review on COVID-19 vaccine acceptance and hesitancy among patients with cancer during the COVID-19 pandemic. Cancer patients are at high risk of getting COVID-19 because of their immunocompromised state. National Comprehensive Cancer Network guidelines recommend the COVID-19 vaccination for the cancer patients. This study aims to identify the current state of vaccine acceptance in cancer patients, and this study identifies the independent predictors for vaccine acceptance and hesitancy. This is a systematic review study. We search in PubMed, Science-Direct and Cochrane COVID-19 Study Registry in primary search. Other than that, we did secondary literature search in Google, Google Scholar and ResearchGate. Studies were selected according to the predefined inclusion and exclusion criteria. Participants who are diagnosed as cancer were selected for the study. Participants with life-limiting conditions other than cancer were excluded. Age should be more than 18 years. All the studies should be subjected to assess the vaccine acceptance or hesitancy. Cross-sectional studies were selected for the final analysis. 2 independent authors performed the study selection and eligibility assessment process. We use JBI, Joanna Briggs Institute Quality Appraisal Tool for cross-sectional studies to assess the risk of bias in each study. Fair and good quality studies were abstracted and any discrepancies, gaps were discussed. Then we entered the abstracted data to the summary table and Excel spreadsheet. Before data analysis, we checked the consistency of the data. Clinically consistent data pooled together. This study followed the PRISMA 2020 guidelines and study protocol was registered in Prospero. For the final analysis, we selected 13 studies. 10 studies reported the fair quality and 3 studies were in good quality. This review represents the Rome, France, Poland, Korea, US, Mexico, Tunisia, China, Lebanon and India. Total sample size was 12,762. Among them, 64.3% accept the COVID-19 vaccine. Based on available data, 46.1% females hesitant to be vaccinated against the COVID-19 vaccine. 38.3% males hesitate the COVID-19 vaccine. Female gender is an independent predictor of vaccine hesitancy. This may be due to the concerns about fear of vaccine-related side effects and safety. Old age, high education level, and compliance with previous influenza vaccination are other independent predictors of vaccine hesitancy. Fear of vaccine-related side effects, concerns of vaccine efficacy and safety, ongoing active anti-cancer treatments, skepticism of rapid development of the COVID-19 vaccine are other causes behind the COVID-19 vaccine hesitancy. There was an interesting finding in this study. Vaccine accepted cancer patients depend on their oncologist's recommendation on COVID-19 vaccination other than their personal opinion. This study shows the requirement of well-designed, problem-based educational intervention to enhance the COVID-19 vaccine compliance among cancer patients. Thank you.
Thank you, Ms.
Ali,
Prabhani.
can I ask a
It's
question?
open for questions now.
Okay. Ms. Prabhani, so I understand that you pulled the data from those studies and looked at them holistically, but were you able to look at, in the pool, were you able to look at the two populations of people, healthcare workers from developed countries and developing countries?
No, sir. Yes. Not healthcare workers, the cancer patients.
Sorry, cancer patients. Sorry, yeah.
Yes, sir. Yes, sure. There are some patients in US, Mexico, and there's one study in India, and there was a study in Lebanon as well.
Yes, my question is whether you were able to or wanted to compare patients from those two groups of countries.
No, sir. I didn't compare that.
Okay, right.
Any more questions from the panel, sir?
I'm fine. Thank you. Thank you.
Ravi, sorry, if sir doesn't have another question, I would like to ask another one if there's time.
Yes, sir. Yes, sir.
Prabhani, did you say that certain factors were associated with vaccine hesitancy?
Yes.
So that means they hesitated to take the vaccine?
Yes.
So what were those factors?
Female gender. Female gender is a strong independent predictor of vaccine hesitancy, and cancer patients with high education level are more prone to accept the vaccine other than vaccine hesitant population.
Not hesitancy, but acceptance.
Yes, accepted. Yes.
I was surprised when you said hesitancy among educated people.
Yes.
So now, even with regard to gender, I think some 40% had hesitancy in the females, and the males were about 30%. That's hesitancy is 30%, less than the females.
Yes, sir. Yes.
Right. Okay, thank you.
Thank you, Ms. Prabhani.
Okay, sir. Thank you very much.
We'll move to the next poster number 6, and presented by Dr. A.T. Matthias. Over to you, Dr. Matthias.
A multi-center study on knowledge, awareness, and practice of familial hypercholesteremia among doctors in Sri Lanka. As we all know, familial hypercholesteremia causes premature cardiovascular disease. It is characterized by increased LDL, xanthomata, and premature atherosclerotic cardiovascular disease. Familial hypercholesteremia is known to have a prevalence of 1 in 220 globally. And it is estimated that out of the population of FH patients living all over the world, around 50% live in Asia. And from studies done previously on FH or familial hypercholesteremia, it has been proven that lack of awareness among doctors leads to underdiagnosis and undertreatment of familial hypercholesteremia. With this background, we set about in conducting a study at 2 large tertiary care hospitals in the Western Province, namely the National Hospital of Sri Lanka and Colombo South Teaching Hospital. And our inclusion criteria was around 50 doctors who attend to more than 50 or more patients per month, working in medical subspecialties, pediatric and surgical wards. And we included all doctors who were willing to participate within 2 weeks. and the link of the questionnaire was given to them. The questionnaire that was used in this study was a questionnaire that has been validated before by Bell et al. And it has been used in other countries for the assessment of knowledge, awareness and practice of FH. So moving on to the results of our study, out of the 300 doctors to whom the link was given, 269 responses were recorded. And moving on to the first segment of our study, that is on knowledge, acceptable knowledge was reported on familial hypercholesteremia description and lipid profile in 66.42 and 39.81% of the doctors. And the prevalence identification was much lower, with 16.60% identifying the correct prevalence of familial hypercholesteremia. The knowledge about heritability was also suboptimal, with only 38.78% identifying it. Familial hypercholesteremia poses a major public health threat because affected individuals are at increased risk of premature cardiovascular disease. And the doctors who considered premature cardiovascular disease correctly as 55 in a male and 60 in a female was very low in this study, with only 1 and 2 respectively. And the optimal LDL goal was identified only by 39.81% of the population. And the CVD risk associated with FH was only identified by 4.55% of the doctors. Moving on to the next segment, that is awareness. Awareness of the cascade screening for patients with FH was also found to be lower among the respondents, as only 35% knew about it. And moving on to practice, the majority of the doctors stated that they would screen the patient relations and close relatives for FH once the index case is diagnosed. And that was 44.66% of the doctors who would do that screening. So in conclusion, the diagnosis of FH could be improved if doctors understood the true prevalence of FH. And in our study, the identification of prevalence of FH was suboptimal. And many premature cardiovascular disease would not have screening for FH if they're not considered premature. And the identification of the age categories or age cutoff for premature was also suboptimal. And this would lead to underscreening of FH. This present study helps in creating awareness about FH, and it's the first of its kind done in Sri Lanka. This highlights important deficits in knowledge and awareness among doctors. And though the doctors believed they were familiar with FH, the knowledge regarding FH was not adequate. And further educational activities need to be carried out in the form of continuous medical activities to help doctors identify the lipid profile indicative of FH. And unless the lipid profile is identified in patients with possible FH, the possible cases of familial hypercholesteremia and thereafter screening for other patients will not take place in routine practice. Thank you.
Dr. Matthias, can you hear me?
Yes, I can
hear
you.
Yes. Two questions. One is, I note with interest that you have done this study in doctors working in 2 hospitals in medical, surgical and pediatric. Why did you choose the surgical and pediatric? Anyway, they will not be dealing with this familial hypercholesteremia. Why?
Yes, surgical, sir, because some other patients, they come with xanthomata and they get their lesions excised, either from the dermat clinic or from the outpatient surgical casualty, so that's why. And pediatrics, because nephrotic syndrome and patients like that, they undergo lipid profile, and sometimes the identification of familial hypercholesteremia, if it is a homozygous familial hypercholesteremia, is usually diagnosed during pediatric life. Sir. The heterozygous is what we identify in adult life.
And the second thing is, did you find any difference in this knowledge of different level of doctors, like interns, SHOs, registrars, senior registrars?
No, sir. We actually tried to, sir, but the group was so heterogeneous, sir, it was impossible to do that with a reasonable statistical significance, sir. Because this actually we had started, sir, halfway when the next wave of COVID came. So we changed our sampling and limited it to 2 weeks, sir. That's why.
Thank you. Thank you.
Tushara, can I ask a
Yes.
question?
Yes.
What exactly is your recommendation?
So I think so this idea of doing the knowledge attitude practice simply in 2 large scale hospitals was now these patients do get referred to this kind of hospitals. So if we know that there are deficits in knowledge, so even doing this questionnaire lets them think about this entity. Otherwise, unless you think about this entity, the screening will not take place.
So you did the study to improve, to make them learn. Is that the reason why you did the study?
No, sir, to identify, sir, what the present level of knowledge was, sir.
So my
So now
question,
that we know that it is deficits, sir, we can actually do something to improve it.
so my question is, what is your recommendation exactly?
Sir, to carry out some continuous medical activities on FH, given that South Asia has the highest burden of cardiovascular disease, to do some educational programs telling people how to identify patients with FH.
People.
That's patients with FH. And
Name-
once you identify the patients, thereafter cascade screening can take place.
No, the education
Time's up for
program.
the Q&A session.
What, sir?
The education program is for people.
For the doctors, sir.
What doctors?
So doctors who are dealing in medical subspecialties and surgical wards, sir.
Okay, thank you.
Thank you, Dr. Matthias. We'll move to the next poster, poster number 7, presented by Dr. UAWL Pereira. Over to you, Dr. Pereira.
Good morning, everyone. Our study is on knowledge, attitude, and practices regarding pain management among medical officers of Sri Jawaharlal General Hospital. As you all know, pain is defined as unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, according to International Association for the Study of Pain. Inadequate pain management of doctors can result in increase in hospital stay and delayed recovery of patients. Our study was a descriptive cross-sectional study carried out among 102 subjects. It was done by using simple random sampling of MBBS qualified medical doctors at Sri Jawaharlal General Hospital. Data were collected using self-administered standardized questionnaire based on knowledge and attitude surveys regarding pain, CAS RP2. It was analyzed using SPSS 20. The study sample consists of 102, out of which 38 were females and 64 were males. The mean CAS-RP score among those with work experience between 1 to 5 years was 55.53%, while mean CAS-RP score were 59.21% and 57.5% for those with work experience for 6 to 10 years and more than 10 years respectively. However, there was no statistically significant correlation between years of experience and CAS-RP score according to Spearman non-parametric test, p-value of 0.073, and there was no statistically significant difference of mean CAS-RP scores between any category of years of experience according to the one-way ANOVA test. The mean CAS-RP score among the intern medical officers was 49.4%, and the mean CAS-RP score among senior medical officers was 56.5%. The highest mean CAS-RP score in this categorization was among postgraduate trainees with mean CAS-RP score of 61.9%. There is a statistically significant difference of mean scores between groups of level of qualification of doctors according to one-way ANOVA test, p-value of 0.002. So in our study, the mean CAS-RP score among the population was 56.25%. The highest CAS-RP score was 78%. Lowest CAS-RP score was 25%. This third graph shows that there is no statistically significant difference of mean CAS-RP scores among age categories according to one-way ANOVA test, showing a p-value of 0.058. So our conclusion was knowledge, attitude, and practices on pain management among doctors in Sri Jawaharlal General Hospital are not satisfactory. Postgraduate trainees who got the highest mark in CASAT score in our study undergo CME activities and workshops on pain management during their training. Workshops on pain management can be used to improve knowledge, attitude, and practices of pain management among other categories of doctors. So we need to distribute pain assessment tools among boards to educate staff on proper pain assessment. And we need to refer these patients to specialized pain clinics whenever needed. Thank you very much. These are my references.
If I may ask a question from Dr. Pereira. Hello.
Yes, sir. Yes, sir.
Right. Hello. I would imagine that in your questionnaire, there must be various aspects of pain management that would have been covered.
Yes, sir.
So what are those areas, and was there any area where they were particularly poor or particularly better?
About the doses, they were not aware, sir, regarding the opioid doses, the half-life, and all, whether they can use tramadol, morphine together. There were questions like that. So they were not aware of the doses. Knowledge was very poor, sir. And we assessed there are some practices like giving DW when the patient is telling pain. So most thinking that they should use DW. So like that, things like those practices, wrong practices, they were assessed in the questionnaire, sir. And the spiritual beliefs, like attitudes of the healthcare workers were assessed, sir. So all three types of questions were there in that questionnaire, sir. So out of all three, knowledge was poor, sir. And that practices like using DW, it was significantly high among those doctors.
So this questionnaire did not cover the aspect of diagnosis.
Diagnosis.
The reason for the pain, whether it is psychological, whether it is organic, that kind of disease, or whether it's combined, whether there were psychiatric problems like depression and things which are, so I mean, were those things, when you say management, it also includes finding out the exact reasons, no? That's why I asked.
For cancer pain, what is the best drug? Things like that were assessed, sir. Psychiatric aspect was not assessed, sir. About the adjuvants, cancer pain, what is the best drug, and for the bone pain, so like that, things like that were assessed, but psychiatric aspects we didn't assess.
So it's mainly focused on treatment, on therapy.
Yeah, therapy.
Thank you.
Can I ask you one question?
Sure, sir.
About attitude, actually, in the one other thing about the pain management is not only the knowledge and the attitude of the doctors who are looking after, you know, how did the questionnaire look, you know, in the sense, if the doctor is not going to care about somebody shouting on the corner of the bed, then all, you know, that is something which we find again and again in the wards, you know, people are shouting and no one is bothered to. So how did you find about the attitudes of what did you find in the attitudes? Because you said in the objective attitudes also.
When the children are complaining of pain, whether you consider that as significant, there was a question like that, sir. And in elderly, better to, when they are complaining of pain, like whether you are going to let them suffer or not. There were two questions like that.
Yeah, so, nobody is going, just a comment actually, is not a question. Nobody is going to say that in a questionnaire, I am going to let the patient suffer, you know, so that will be not, you know, if you are going to see whether in a questionnaire asking a doctor, are you going to let the patient to suffer? No, my comment is actually attitudes are very difficult to assess. Now though people are coming out with various ways of assessing attitudes, but one other thing which we don't check in the...
Time's up for the Q&A session.
Okay, thank you. Okay.
Thank you.
Thank you, Dr. Pereira. Let's move to the next poster, number 8, presented by Dr. S. Senanayake.
A very good day to all of you. Hypertension and tachycardia are two common entities that we come across as clinicians in our day-to-day practice. However, they can be the presenting features of some rare diseases as well. We would like to present a case of a parathyroid adenoma presenting as unexplained sinus tachycardia and refractory hypertension. So primary hyperparathyroidism and malignancy account for most of the cases of hypercalcemia in clinical practice. And they commonly occur in relation to either a solitary parathyroid adenoma, parathyroid hyperplasia, and rarely carcinoma. And majority of these patients are asymptomatic and found incidentally. However, some patients present with vague unusual symptoms which make the diagnosis delayed. So we report a case of a 50-year-old lady presenting with vague ill health for 1 year's duration, during which time she was investigated extensively and seen by multiple general practitioners and physicians, where they found the patient had a resting tachycardia, which was confirmed by a Holter as unexplained sinus tachycardia. And her blood pressure control was erratic, even with maximum doses of multiple antihypertensive medication. She had a background history of long-standing type 2 diabetes with early chronic kidney disease. She had dyslipidemia and previously well-controlled hypertension. Further evaluation of this patient for causes of secondary hypertension showed normal results in most of her investigations, except a marginally elevated serum ionized calcium with a normal serum phosphate level. Her vitamin D levels were very low as well. However, due to clinical suspicion, the performance of an intact parathyroid hormone level was done and it was elevated. That led to further evaluation, where the clinical evaluation revealed an anterior neck lump, and that was ultrasonically confirmed as a thyroid enlargement with the possibility of a deep-seated parathyroid mass. A SESTIMI-B scan confirmed the presence of a single parathyroid adenoma, and the possibility of multiple endocrine neoplasia was ruled out in this patient. And she underwent a successful partial thyroidectomy with removal of the parathyroid mass as well. And the histology revealed a solitary benign parathyroid adenoma. Following her surgery, her serum calcium levels actually returned to normal range, and her unexplained tachycardia also settled, as well as her general well-being. And her blood pressure was controlled with 3 antihypertensives. So this case depicts the importance of considering hypercalcemia as a rare possibility in the workup of unexplained tachycardia and hypertension, especially in our country where vitamin D deficiency is quite prevalent. That might mask the degree of hypercalcemia. And this patient also had a background history of chronic kidney disease, which might have been the reason for the normal phosphate level. So always keep in mind that hypercalcemia could be one of the causes for refractory hypertension as physicians. Thank you.
May I ask a question?
Yes, sir.
Yeah. So why do you think the patient's blood pressure or hypertension persisted after the surgery and correction of serum calcium?
Well, sir, yeah, thank you for your question. Normally, what happens is if you have long-standing damage and change in the microvascular circulation, the microvasculature, the hypertension might persist. Even we went through literature. When you have long-standing hypercalcemia and when the damage has already been done, the other problem is she had a certain degree of chronic kidney disease as well. So that might have been one reason why her blood pressure was still elevated. The other thing is, even in the literature, it says that long-term hypercalcemia, the damage it causes will lead to some degree of hypertension being persistent. So
what does it
that's
mean
well
by
documented.
damage? Yeah. So what does it mean when it says the damage that has been done? I mean, what is the pathophysiological changes which enables or which makes blood pressure persistent? What do you mean by damage has been done? What is this damage?
Arteriosclerosis and the calcification of the arteries will make the compliance less. So that is one reason that it will persist.
But that would normally, it might increase the systolic, but it actually reduce the diastolic pressure.
I'm sorry, sir?
When the elasticity is lost, it might cause an increase in systolic if the stroke volume is good, but it will cause a drop in the diastolic pressure.
Drop in the diastolic, but this patient, mainly the hypertension was more systolic. There was a diastolic elevation as well, but mainly the systolic blood pressure was over 200 most of the time. So that is what
Time's up for the Q&A session.
Okay, thank you.